you talk to me a little bit about dynamic measures and dynamic assessments? What are they?
It's a great question. A dynamic measure is really what we've been looking at and what we've been searching for a long, long time. Basically what it is before we give fluid, we want to test the heart to see what's going to happen when it receives fluid. So a dynamic measure is very simply, it's a small challenge to the heart and watching how the heart handles that response. Does it increase stroke volume by more than 10%? If so, that is highly predictive that when you actually go ahead and give additional fluid, that you'll get a sustained rise in cardiac output. If the stroke volume index does not change by more than 10%, it is highly unlikely that when you give fluid, you'll actually see a sustained rise in cardiac output. So it's really a measure of whether or not fluid is going to be effective at improving cardiac output and helping you improve perfusion.
That sounds very straightforward.
Indeed.
So then why is a dynamic measure better than the quote-unquote, old way of assessing a patient's fluid needs?
Well, I think the dynamic measure is what we've always wanted. It's what we've always been searching for. It's just until we've had the ability to look at stroke volume change, cardiac output change at the bedside non-invasively, and we've had technologies that have the precision down under 10% that let us do this. We haven't had access to this before.
So what are some ways of actually performing a dynamic measure?
One of the easiest ways is actually, and it demonstrates the physiology really, really well, is doing what's called a passive leg raise.
Okay.
So if you actually raise both lower extremities, you get about 250 to 300 cc's of blood in an average size adult, quickly coming back to the heart. So when you do that maneuver and you get that 250 to 300 cc's of blood coming back, watching what the heart does with that and whether or not it actually increases cardiac output is one of the ways of executing a passive leg raise.
Okay.
The beauty of this is you put the legs down, fluid goes back, no harm, no foul, no additional fluid. It's
Nice.
a very good diagnostic test. In fact, it's been very well studied, and when you look at the statistics around this, the sensitivity and specificity are both in the upper 90s.
Oh, wow.
The receiver operating curve, which is another statistical measure, is over 0.9. This is a really good performing test when it comes to predicting whether or not patients are going to have a sustained rise in cardiac output with fluid. In fact, it's performing at the level of tests that we use commonly all the time, such as serum creatinine, thyroid function test. In fact, it's on the order of troponin as far as sensitivity and specificities in predicting
So very
response.
accurate.
It's very accurate.
Very accurate.
Yeah.
So then what happens if I can't do a passive leg raise for some reason?
Well, you can mimic the physiology. So you can mimic that by giving an extrinsic fluid bolus. So actually, providing the patient with a small fluid bolus. Now, what you want to do when you do this, though, is you want to mimic the physiology of a passive leg raise.
Okay.
So if you think about with a passive leg raise, the fluid translocates in 2 to 3 minutes. It's very
Right.
fast.
Right.
So if you're giving an extrinsic bolus, you want to give that very quickly as well. This isn't over 15, 30 minutes. This is over 2 to 3, 5 minutes, a very quick fluid bolus. And watching what the heart does with that. And again, if the stroke volume goes up by 10% or more, it's highly predictive that you'll see a sustained rise in cardiac output. If you don't see that 10% rise, then it's highly unlikely that the patient will actually have a sustained rise in cardiac output with additional fluid.
So then my next question is, what if I'm with a very critically ill patient and I simply am, or in an emergent situation, what do I do if I can't do a leg lift or I don't have time to spike a bag and put it on a pressure bag?
Sure. Well, of course, what you want to do is take care of the patient
Sure.
and stabilize the patient. I think, in those settings where you're giving fluid and an active, resuscitation, if you can get the cheetah monitor on, if you can get the sensors on and watch, you can actually see, are you seeing a rise in cardiac output, a rise in stroke volume with the fluid that you're actually giving? So is the fluid working? Of course, what we typically do in those situations is we do a mix of fluid and pressors.
Sure.
We do what we can to get the patient stabilized, and you certainly want to continue to do that. I would say, once you get the patient stabilized, then you can also look at how do you titrate therapy and adjust fluid versus pressors. It's a great time to come back and revisit fluid responsiveness.
So really there's no time when you couldn't use cheetah. you could trend, you could do a leg lift, or you could do a bolus.
Absolutely.
Okay.
And I mean, I think
wide application.
Yeah, exactly. And so, the thing here is what you want to be thinking about, is the fluid that you're giving effective?
Sure.
So you can do a diagnostic test up front to know before you give fluid. If you really are committed to giving fluid, you can also check and see, is the fluid having an impact? Is it having the right effect?
Sure.
So
Okay.
it's, diagnostic versus watching, is your therapy effective?
Okay. So then talk to me about who's endorsing this approach.
Well, the dynamic approach, again, I think is the physiologic approach we've been striving for a long time. We've been looking for it. And really only with the advent of these technologies at the bedside can you now get there. And that's
Sure.
very exciting. Some of the earlier endorsements, NICE in the UK endorsed this in surgery back in 2010, approach of using dynamic measures to guide fluid responsiveness. The European critical care societies began to endorse this shortly thereafter in 2011, 2012. Here in the U.S., CMS has adopted it, endorsed it in their sepsis measures, and of course the Surviving Sepsis campaign also endorses the use of dynamic measures and this physiologic approach to guide your fluid management.
So worldwide then?
Yes,
Okay.
yes.
All right. When should I perform a PLR on what type of patient?
It's a great question. I mean, it's a question we get frequently, I think. Anytime that you are wanting to give fluid as therapy, that you're trying to improve perfusion of a patient, you're trying to fix a blood pressure, trying to fix a low urine output, or ECG, a high lactate, whatever it is that you're trying to improve the perfusion by giving fluid, you want to check and make sure, is that fluid going to be effective?
Okay.
Or as you're giving it, is it actually having the impact?
Okay.
So that is the time where you want to intervene and actually check, is the fluid going to be effective? If it isn't, then you want to think twice before you continue to give fluid, because we know the complications associated with fluid overload and volume. The ability to sort of load them up and take it off later, that doesn't work so much.
Sure. So then how often should I be repeating that assessment? If I'm going to be doing a dynamic assessment and I do a leg lift, let's say I intervene, I end up giving my patient fluid because they were fluid responsive, when do I come back and recheck?
I think you come back and recheck when you're concerned about the perfusion of the patient.
Okay.
And if you're actively managing the patient's perfusion. If the blood pressure is okay, the cardiac output is okay, and all that, you're not going to do anything, there's no need to intervene.
Okay.
You don't necessarily need to check. But certainly if you're looking at, can you substitute fluid for pressors, you're trying to adjust pressors, it's a good chance to look. Is there a time where you want to give additional fluid? You should be thinking about checking to make sure that the dosing of that fluid is going to work and it's
Okay.
going to be effective. That's when you do it.
Okay, that helps. So this is non-invasive, and a leg lift is also a non-invasive maneuver. To me, as a nurse, this can be entirely nurse-driven.
I think it's a great point. And what we see typically with customers, this gets written into protocols, it gets written into orders. Anytime that you're giving a fluid bolus, check first.